We welcome you again and good afternoon. Thank you for joining National Caucus and Center on Black Aging Incorporated, NCBA, and Dr. Cheryl Reynolds for our webinar today on controlling diabetes for better eye health in African Americans. Again, as we welcome our presenter, Dr. Reynolds is a professor at the Nova Southeastern University College of Optometry. She was past president of the National Optometric Association, NOA. She is a planning group member of the NEI, National Eye Health Education Program, NEHEP, and is co-chair of NEHEP Eye Health My Health campaign that fosters eye health for African Americans. Dr. Reynolds, once again, thank you so kindly. We appreciate you. The floor is yours.
Thank you so much for having me. It's really a pleasure to be here. And I want to apologize to everyone for my slight technical difficulties. Computers can always be a bit of a challenge. However, this slight technical difficulty will not stop us from having a impactful next 50 minutes or so discussion on diabetes. I want to start off by just highlighting that this month is not only the month of Thanksgiving, but it's also the month of diabetes awareness. And it's so critically important that everyone is aware of this condition because it is an epidemic and it's not slowing down. The numbers are just increasing exponentially. For example, in the United States, most of you probably don't know, but half of our population have diabetes and or maybe at risk of developing diabetes. That's 130 million people in the United States that have diabetes or at risk of having diabetes. When we look at the numbers, it's really just increasing again, not just in the United States, but worldwide. 500 million people have some stage of diabetes or pre-diabetes, and by 2050, that number is expected to explode to 1 billion people. And in the United States, the numbers, when you look at the current data on patients with diabetes or individuals with diabetes, is expected to increase as well to, right now, 38 million people have diabetes, and 96 million people have prediabetes. The number of patients expected to have full-blown diabetes, a diagnosis of diabetes by 2050 is expected to be roughly 60 million. So the numbers just keep going up. So this month of Thanksgiving, yes, it is Thanksgiving, but it's also Diabetes Awareness Month. So I'm going to spend the next few minutes talking about controlling diabetes for better eye health in African Americans. My PowerPoint presentation will be pretty short. What I really want to do is answer any concerns, any questions the audience may have about diabetes, because what I feel, and I have experienced with my patients for the last 25 years of being in practice, is that a lot of my patients come in not really understanding their disease. They come in and they may say they have borderline diabetes, not full-blown diabetes, or they may use terms like I have a touch of sugar, or, they told me I have diabetes, but I really don't have diabetes. So I thought I would kind of go through diabetes again, just so that you guys can understand the disease, but also to allow you guys more of an opportunity to ask questions. Again, these are my disclosures or who I am, and I'm again very happy to be here. I am on the planning group for the National Eye Health Education Program, NEHAP, as well as the chair of their Eye Health, My Health, Eye Health for African American Committee. And so I'm going to give you some resources that the NEI NEHAP has for our patients if you want to follow up from some educational resources at the very end. I always start the lecture by asking the audience, and I've asked Angela to kind of guide me a little bit and come on and give me some numbers in the chat because I can't really see the chat that well. But do you know, or do you have a family member? Do you know someone that have diabetes, or yourself that have diabetes? And I'm pretty sure without looking or seeing the chat, pretty sure much everyone should be raising their hands that they know someone or they have the disease themselves or there's the disease in the family. So Angela,
Yeah. Yes, absolutely. Four participants have raised their hands, and many are saying yes. Several family members. Yes, yes,
Yes,
several.
yes, yes. You know, I have to say for myself too, my aunt had diabetes. She lost her vision to diabetes. She also lost, a couple of amputation of her toes from diabetes. So, diabetes touch all of us, whether it touches us ourselves, but we know someone. For me, my patients disproportionately, again, it's in my family, friends have family members that have diabetes. And what's really important during this Diabetes Awareness Month, November, again, it's the month of Thanksgiving, but I just really want to highlight that everyone that has diabetes should be having a comprehensive eye exam. And I'll tell you why in just a few minutes. And so if you have family, friends, anyone that has diabetes, make sure you're asking them if they're getting their eyes examined. What is diabetes? Diabetes is a complex disease, really, honestly. When we look at the pathophysiology, there's so many different thought process as to this underlying condition. But what we do know that it's a deficiency of insulin secretion and or insulin effect, right? We also know that patients who have elevated blood sugar level, term hyperglycemia, that can lead to a lot of complications in the body. It can disturb the carbohydrate, the fat, the protein, and this lead to a constellation of problems. It can impact the eyes. As we go through this PowerPoint presentation, it's important to note that the leading cause of vision loss in working age adults, those individuals who are 20 to 74 young, is diabetes impacting the eyes. And it could be diabetic retinopathy, diabetic maculopathy, and other complications in the eyes that are attributable to diabetes. We know that diabetes can impact the kidneys. In fact, the number one cause of end stage renal disease is diabetes. After that, it's blood pressure. So patients with diabetes, not only do they have it, that it can impact from the top of their hair to the bottom of their feet, but their eyes, their kidneys. Again, it can affect their feet. The leading cause of non-traumatic amputation in the United States is diabetes affecting, your toes, amputation of, various parts of your toes or even your limb from diabetes, poor circulation, and these are microvascular complication or small blood vessel complication. Diabetes is one of the leading causes of stroke, as well as heart disease and a number of other complications as well. When we think about diabetes, everyone on this call right now have been told they have diabetes, but it's really important to know what type. For example, patients with type 1 diabetes, they need insulin to live, right? So the body attacks its own beta cells, and so they do not produce insulin. So they require exogenous insulin to live. And you're diagnosed earlier. So these are younger patients with type 1 diabetes. What's important about this is patients with type 1, they definitely have to get an eye exam because they're more susceptible to having eye complications because they have the disease longer. Then if you are older, again, genetics plays an important role. If you have a family member who has diabetes older, you're more likely to get diabetes. But one of the things that also contribute to you developing diabetes is your weight, obesity. There's a term diabesity that says that patients that are obese are at risk for other complications. And one of those complications is diabetes, new onset diabetes. And there are new medications out there now for patients where it's weight and these medications that help you to lose weight, Zempic and Manjaro and Wegovy, these medications that you've seen commercials about help you to lose weight, to help your diabetes. So yes, weight obesity can contribute to type 2 diabetes onset, but the number one cause of that again is genetics. Then you have patients who've had diabetes during pregnancy. If you know family members who've had diabetes during pregnancy, they're at risk of developing type 2 diabetes. Up to 60% of those patients develop type 2 diabetes within 5 years of having their baby. So they should be getting an eye exam and being followed. And then there are other conditions or other causative factors, such as late autoimmune diabetes. And not to be too detailed, but there's other reasons that you can get diabetes. Sometimes medication, if you're taking medication such as prednisolone, it can also cause you to become hyperglycemic and lead to type 2 diabetes. Now, prediabetes. Prediabetes, again, 96 million people in the United States have prediabetes, and those are individuals that have elevated diabetes, but it's not elevated enough to be on medication. That group of individual, again, a lot of time it has to do with weight, diet. They have to do some lifestyle modification, exercise a little bit more, so that they don't develop full-blown type 2 diabetes. Again, I mentioned this, so let's see in the chat, Angela, if the audience is listening. What is the leading cause of vision loss in working age adults? Let's see if anyone puts that in the chat, Angela.
Okay, I have diabetes.
Diabetes is, and the complication from diabetes, Miss Angela, is diabetic retinopathy. Diabetic retinopathy, where it affects the eyes, it causes the blood vessels to become weaker over time. When those blood vessels become weak, they can leak blood and bleed. And so you can see from all of these images here, you can see different areas of the back of the eyes. This is your retina. So when you go to an eye exam, it's important that the eye practitioner, whether it's an optometrist, ophthalmologist, dilates the eyes. Some patients, some doctors might take pictures of the eyes. When we do diabetes screening, it's taking an image of the retina. So these images are of the retina. Also, you're seeing in that center part here, this is your optic nerve that transmit your visual world to your brain. And, the nerve is where we see glaucoma that can impact patients that have diabetes. In fact, patients that have diabetes are at higher risk of developing glaucoma, but also causes new blood vessels to grow around the nerve if they have really severe diabetes. So these images just kind of highlight different stages of diabetes. This top image here, all these yellow spots are leakage of blood vessels. So not only do they leak blood, but they also leak fluid type changes. And that fluid can accumulate in the patient's center part of their vision, called the macula, and it causes them to have blurry, wavy, fuzzy vision. Of course, patients can have diabetes in the eye and still have good vision. They can be 20/20 and not know that they have severe disease. That is why an eye exam is so critically important. You can't detect diabetes by just symptoms. You don't feel diabetes. You won't have red eyes, sudden loss of vision unless a broken blood vessel occurs and there's blood in the eye. So that's why it's important to get an eye exam to detect these early changes in the back of the eye. And once we detect these early changes, we can monitor you more closely, or we refer you to our colleagues, a retinal specialist, where they might treat you with injection in the eye to cause these blood vessels not to bleed anymore, or to leak anymore, or these new blood vessels not to develop anymore or to regress. So diabetic retinopathy is the leading cause, maculopathy, of vision loss in working age adults. I put this slide in here because it was just published in 2024. There was a recent study that looked at the prevalence of patients that have diabetes and diabetic retinopathy, and the call to action, and this is why this is important for me to do this presentation during Diabetes Awareness Month, is that 1 in 4 people with diabetes have some eye damage. That's significant. 1 in 4 individuals on this call who have diabetes have some stage of diabetes affecting the back of the eyes. And so that's, again, just another reason why it's important to have a comprehensive eye exam. I saw this slide, and I want to give credit to the National Eye Institute and Kodak Vision Institute. I thought it was really a great summary of everything I would say. So I just kind of like put this in here. Again, 5 things that you should know about diabetes, eye disease. As I mentioned earlier, number one, diabetes can affect from the top of the head to the bottom of the feet. We know that it can impact the eyes significantly. It is the leading cause of blindness when patients have diabetic retinopathy, but they may have other problems. I mentioned this earlier. Patients with diabetes are at higher risk for having glaucoma. And when you have glaucoma, it causes you to lose your peripheral vision. As this schematic shows, it causes the patient to lose their peripheral vision and they just have central vision. And then over time, that central vision can also become compromised. Glaucoma is the silent thief of vision. There are no symptoms with glaucoma. Once you have an eye exam, that's the best way to detect glaucoma. And then your eye practitioner, your eye doctor will treat you with eye drops. And in some cases, you may need eye drops, more than one. And in some cases, you need the drops and surgery as well if the glaucoma has advanced. Additionally, patients with diabetes are at a higher risk for cataracts. And when you have cataracts, that's your lens in the eye becomes hazy over time. When it becomes hazy over time, you need surgery to remove the cataracts and put an implant in the eye so you can see much clearer. Then, as I mentioned, number two, patients with diabetes are at a higher risk for developing diabetic retinopathy. That is why an eye exam is so critically important. If we can detect it in the early stages of the condition, then we can help to preserve the patient's sight. The other thing that's important to note is that, among patients with diabetes, the risk of retinopathy significantly gets higher, and it's even higher when you are not well controlled. And what I mean by control is patients with diabetes, should know their hemoglobin A1C level. So every 3 months, you have a blood test. They tell you a number of 7, 8. Those are your hemoglobin A1C level. The American Diabetes Association 2024 is recommending that it be closer to 6, so even less than 7. So every 3 months, so you want to know your numbers. You want to control your ABCs. And what does that stand for? Your blood pressure. Patients with diabetes also have blood pressure issues and are on medications for that. So you need to know that your blood pressure needs to be less than 130/80, so that you don't run the risk of developing complications from blood pressure causing diabetes to exacerbate or change, as well as your cholesterol numbers. You want to not smoke. Smoking increases your risk of having diabetes and having diabetes retinopathy in the eye, or diabetic retinopathy and diabetic maculopathy. So you want to have smoking cessation or just quit smoking so that you can prevent and better control your diabetes around just your systemic health as well as your eye health. And then finally, you gotta get a comprehensive eye exam every year. Every patient that has diabetes should be seeing a practitioner every year. If you're diagnosed with any stage of diabetic retinopathy, if you have mild, moderate, severe, then you're seeing your doctor more frequently. If you're being treated by your retinal specialist, you need to follow the retinal specialist advice. I know a lot of times patients are nervous about injections in the eye, but the injections in the eye is the latest, most effective way to treat patients that have diabetic retinopathy now. So your retinal specialist would be injecting a substance that helps to reduce the swelling, reduce the bleeding in the eye, and therefore they're helping you to preserve your sight. I just want to mention there's no reason for patients with diabetes to lose their vision. If you do these 5 things, then you can preserve your vision and preserve your sight if you have diabetes. All right, so these are some of the resources that are available. I will be sharing them with NEHAP, from NEHAP, and sharing them with Angela so that she could share with everyone. But they're there for you as resources as well. And here's some other resources for those that may have financial challenges. The National Eye Health Education and program, as well as the National Eye Institute, has some get free or low cost eye care where you can get those available. And so I'll share those as well with you, Angela, with the PowerPoint. And then you can always connect with NEHAP on social media to learn more about eye health. And we do have our eye health, my health um, page for African American that's up and available. That's also another resource. So now I wanted to open up the floor for questions because this is my opportunity to answer any questions and your opportunity to ask, and I could do my very best in answering any of the audience questions. So Angela, if you don't mind telling me what questions were put in the chat.
Angie will.
Yes, thank you. Thank you, Dr. Reynolds. Thank you for such a thoughtful presentation. And I'm going to start here with the chat. So the first question asks, can you speak more to the eye implant at the cataract surgery? I've not heard about this implant.
So basically, well, when you have a cataract surgery, they put in I would say an IOL. So it's a new, it's not a new, but it's a kind of lens, an implant lens to help you see better. So every cataract surgery, that's what they've been doing forever. So they remove the cataractus lens or part of structure that has become opacified. So when I say someone has cataract, it means there's opacification of the structure, the lens in the eye. So they remove that and they put this silicone implant sort of lens in the eye, and when you look through that, you see much clearer. So that's what a cataract surgery entails. And again, you can, look up cataract surgery. NEHAP has wonderful resources on what cataract is and what cataract surgery is.
Okay, thank you, Dr. Reynolds. The next question in the chat reads, if I'm being treated by a retina care specialist, should my family members have the same care?
That is a very important question. All the questions are important. Again, diabetes is a genetic disease. So if you have diabetes and your children should be checked, your sisters, your brothers, uncles, aunts should be checked for diabetes. And also to diabetes is a family disease. What I mean by that, even if you don't have diabetes, you have to be there for support for your family member that does have diabetes. So one of the things that occurs and we like to educate is just a family support. If someone is going to the retinal specialist, that means that they have diabetic retinopathy or bleeding in the back of the eye, and or they have diabetic maculopathy, and it's interfering with their vision. So again, the injection is to help slow that down, stop the disease, control the disease. And a lot of these patients need support. It's important to bring them to their retinal specialist, to have the injection, to be with them after they have the injection, to make sure that they are following up with care. One of the things that we're noting is a lot of time patients get follow-up fatigue, injection fatigue, so they don't go back. They feel that they're not seeing any better. This injection is not helping, and they don't go back. And the injection is helping. That's why the retinal specialist is injecting the patient to help preserve their sight. But it's important that the family is also a participant or participatory in the patient's eye health care.
Okay, thank you, Dr. Reynolds. And just to build on that a little bit, I have two questions myself. Can I ask you to please give some guidance on how we can get our families involved, how we might broach that conversation? And then secondly, does Medicare, Medicaid, and private insurance readily pay for this type of care?
So the first question is, how do you get your family members and educated on diabetes? It's so important. There are brochures and resources. One of the things that the National Optometric Association has is brochures around our three silent killer: diabetes, high blood pressure, and glaucoma. But there are resources available to kind of explain diabetes and what this disease is. What I will say, something that I did with NEHAP on Right the Vision, a campaign that we worked on, was giving the gift of sight during the holidays. Sometimes it's important to maybe you might have to coordinate the eye exam for a family member that feels they don't need that eye exam. A lot of times patients feel that they see well and they don't need an eye exam, or they think an eye exam is just for glasses. An eye exam by an eye health practitioner, an optometrist, or ophthalmologist is not just for vision. Remember, you can have 20/20 vision or normal vision and have glaucoma, have diabetes, diabetes impacting the eye, diabetic retinopathy, diabetic maculopathy. You can have a tumor in your eye. I always say the eyes are a window in. We can detect high blood pressure, cholesterol, diabetes, and other vascular disease or inflammatory disease. Um, and so we not only just save our patients' sight, we save our patients' lives a lot of times. So I think during the holidays, it's good to give the gift of sight. It's this Thanksgiving. We should be thankful for our sight and preserve our sight. So maybe giving, instead of an expensive gift, an eye exam for our family members. And then also to, if you have family members that have diabetes, just underscoring to them the importance of a comprehensive eye exam. It's important because patients with diabetes are not coming into the office, and we're not sure exactly why. 60% of patients with diabetes don't get an annual eye exam. And so this is my mission to really a sort of call to action to underscore the importance of a comprehensive eye exam. Now, I understand the social determinants of health and some barriers that our patients may face, financial barriers. That's why those resources are available out there. And to answer your second question, yes, insurances does cover an eye exam if you have, Medicare. Medicare will cover, the procedures, the injection procedures that the retinal specialist will have to do. If you have Medicaid, of course, it will cover. Some insurances are HMOs, and so we may have to go through the primary care physician to facilitate care for the patients, but most insurance cover eye health care and eye medical care. So vision, if you have some insurances, you may go just to get vision and get the glasses. But if you need to have glaucoma management, cataract surgery, injection for diabetic retinopathy, that's medical management. And most insurance have a medical component to eye health care. So just check with your insurance to make sure. But the ones that you mentioned, Medicaid, Medicare, and most major health insurance, United Healthcare, Blue Cross Blue Shield, Humana, they cover medical eye health care.
Okay, thank you, Dr. Reynolds. And then our next question asks, can you please define the difference between an ophthalmologist and an optometrist?
Yes, I'm more than happy because I am an optometrist. So optometrist like myself, we do 4 years of optometry school. We do undergrad. I went to University of Florida, did my 4 years. I had my bachelor's in microbiology. So you can do 4 years in undergrad, and then from undergrad, based on your core courses, you apply for optometry school. There is an entrance exam that you take to get into optometry school, and that is the OAT exam, and that's a 4-year commitment education to be an optometrist. Some of us do a residency after we complete our 4 years. We can treat eye disease. We not only check for glasses, contact lenses, and seeing. Some patients need focusing glasses, not so much for reading, but an optometrist might do visual therapy if they do pediatric optometry. Again, we do contact lenses, but we also do eye health, right? We can treat, inflammation and infection in the eye with medication in most states. We can treat glaucoma with medication. We can follow the patients if they have early, moderate, and diabetic retinopathy. An ophthalmologist is an MD or a DO. These individuals can do surgery. So if I have a patient that has cataracts, I can follow the patient until they need the cataract surgery. Then I would refer them to a cataract surgeon. A patient that has early diabetic retinopathy, I could follow those patients very closely every 3-4 months, as I do in my retina service here. And then when they need injection or they have severe disease or proliferative disease, then I will refer these patients to the retinal specialist for injection in the eye. So the biggest difference is that the optometrist is a 4-year degree. We get an OD, Doctor of Optometry degree, and then or optometry doctor degree, and then ophthalmologist is either an MD, so they're a medical doctor, or a DO, and they can do surgery.
Okay, thank you. Thank you very much, Dr. Reynolds. Our next question in the chat reads, what is the difference LADA 1.5 and type 2 diabetes?
So basically, a patient that has type 2 diabetes, those patients, their beta cell receptors don't work over time. They're diagnosed at a later stage, in their 30s or 40s. Again, a lot of times these patients might have concomitant obesity or weight issues. But again, if they have a family member that has diabetes, was diagnosed in their 40s or 30s, this genetics plays an important role. We know that diabetes disproportionately impact African American and minority population of patients, as well as the retinopathy impacted minority patients more disproportionately. When it comes to the 1.5 or LADA, the late onset autoimmune onset diabetes, those are individuals that are in a gray area, like they're 18, 19, 20, and they're diagnosed with either type 2 diabetes, but is it really type 2? These patients may be on insulin as opposed to oral therapy. So again, these are these younger individuals. They're not your type 1, but they're not exactly your type 2, and they may have other conditions that I noted on the PowerPoint. So latent autoimmune disease. Then of course, some patients develop diabetes, hyperglycemia due to medication, pancreatic disease. And these individuals, they didn't necessarily have the genetics for it. They're taking medication. That's why we see an uptick in cases of diabetes due to COVID, because a lot of patients were on anti-inflammatory inhalers or anti-inflammatory because it's an upper respiratory tract infection. And some of these patients develop new onset diabetes because of the medication with that. We typically put those patients in type 2, but I usually put them in that 1.5 category for that. And then, of course, you have your prediabetes where the numbers are just borderline high. You can be from 100 to 125 on a fasting plasma glucose for patients that have prediabetes. So I hope I explained the difference. It's really working with your medical doctor, and they will definitely diagnose you when you're diagnosed as an older person with diabetes. It's typically type 2.
Okay, perfect segue. Dr. Reynolds, can I ask you please to give some guidance of how would one get their care team working in one accord? Many of us, such as myself, I have an internist, I have a dentist, I have an ophthalmologist, blah, 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 blah. And I am not living with diabetes or pre-diabetes, but if I were, how do I get all of my doctors talking so that I can get some good comprehensive care? I mean, many of them ask you to fill out forms, and diabetes is certainly on the form. But how do I know that what I have checked is being taken into account by all of my care providers?
One of the things that is important in the American Diabetes Association has stressed, diabetes educators stress, is a multidisciplinary team. Diabetes team health approach should have not just optometrists, but it should have the dental, like you said, because we know that patients have with diabetes are increased risk of periodontal disease. We know that patients with diabetes should have maybe mental health because patients with diabetes have maybe cognitive decline and depression. Patients not only should have their endocrinologist and their PCP, the pharmacist should be involved. We know exercise and nutrition is important. So should have a nutritionist and someone that is a specialist in exercise, physical therapy, occupational therapy. Those are all individuals that should be part of the diabetes healthcare team. And what's really important, and podiatry as well. Got to mention podiatry. That's important as well. What's important in not just having the team is the team communicating, and it needs to be this bi-directional communication amongst the diabetes healthcare team. What we do as eye care practitioner, as optometrists, is definitely when you see patients with they don't have to have retinopathy or not. we have to communicate that to their PCP and their endocrinologist. So we like to communicate, give a diabetes summary report on the patient's chief complaint, their visual needs, if they got glasses, what's going on. Some patients with diabetes, depending on their blood sugar level, can have fluctuating vision, change in vision. And so we like to document that, make sure that the PCP knows that we're asking the A1C, the blood sugar level, they see their time in range, which is a new parameter if the patient has a CGM. Some patients should know their time in range, or we as optometrists can look at those numbers. But we need to document that at our finding as well to make sure that the patient knows what's going on and that they know their numbers. So in addition to doing that part, we also give the feedback on what their acuities are, if they're 20/20 or not. We give an assessment or feedback on their ocular health, if they have retinopathy or not, and that we recommend a yearly comprehensive eye exam. So for us as eye care practitioners, it's important to communicate with the physicians, their endocrinologists, their primary care physician, but it's also important to communicate if the patient is seeing a podiatrist, what's going on with their eye health, as well as other members of the healthcare team. So I think the best way is communication amongst all members of the diabetes healthcare team. We like to know what the numbers are. We like to know that the patient has been referred. So getting a little note from their PCP with that referral, maybe a little note stating what their A1C numbers are, what their control is like, might be good for us too as optometrists to know, hey, that the patient is being compliant, the patient is following up with care as recommended by the healthcare team. So I think the best thing is communication. I do note that there are some centers where you have all of those members of the healthcare team under one umbrella. And so it's easy for you to see the PCP, the endocrinologist, the dentist, they're all under one umbrella, and that's good. But if they're not under one umbrella, then it's important to communicate via summary report or note.
Okay. Thank you, Dr. Reynolds. Our next question in the chat reads, what is ketoacidosis and how does it affect diabetes?
So ketoacidosis is elevated blood sugar level, hyperglycemia. Your blood is so sweet in our younger. We typically tend to see that in our type 1 patients, the way the numbers are just really, really elevated. They tend to have a free smell to their breath. And so those patients need to be seen by their healthcare practitioner as soon as possible. In some cases, these patients are hospitalized and treated to get their numbers down, significantly down to a better controllable number. So diabetic ketoacidosis is a severe complication that can be seen in patients that have type 1 diabetes, and in some cases type 2 as well.
Okay, thank you. And our next question asks, does a diagnosis of being pre-diabetic go hand in hand with renal impairment? And what are some of the treatment options to be discussed with a provider?
So, if you have renal disease, this is what I always say to patients that have renal disease. If you have renal disease, there's different causes, right? So, working with your nephrologist, your primary care physician, and elucidating the cause. It could be high blood pressure, it could be something congenital that's causing your renal issue. What happens is a lot of times patients will have prediabetes as well as other comorbidity. Just know that having prediabetes is something that if you don't incorporate these mitigating factor lifestyle changes, weight loss, that you develop full type 2 diabetes, you have another layer of another condition that can make your kidney disease worse or your kidney disease more impacted. So it's important for patients that have renal condition and prediabetes to make sure that they're following up with their doctors and managing their prediabetes with those lifestyle modification. For patients that have type 2 diabetes, one of the complications that can occur is diabetic nephropathy, where the kidney doesn't work as well for these patients, in addition to diabetic retinopathy. A lot of times, if I have a patient that has diabetic nephropathy, if they're on, dialysis treatment. I look carefully in the eyes for retinopathy because we know that there microvascular changes have been compromised. And these small blood vessel in the kidney, if they have it in the kidney, then the eyes can be impacted, as well as neuropathy, which is diabetes, nerve pain, ulcers underneath the foot. Patients don't feel that their nerves don't work as well, so they don't feel the bottom of their feet. They can have sores. That's what leads to the amputation of a digit or their toe, because they don't know that something's going on at the bottom of their feet. And so they step into something and it becomes gangrenous or infected more. And so that's why podiatry is so critically important. But just note that if you do have kidney disease and you have prediabetes, you want to manage that very well with your lifestyle modification. And if you have kidney disease and diabetes could potentially exacerbate the kidney disease or be the cause of your kidney disease.
Okay, thank you. Thank you, Dr. Reynolds. Dr. Reynolds, you spoke to smoking and the need to just stop smoking. Does that include the question in our chat asked, does that include all forms of nicotine, including vaping and marijuana? And then
Yeah.
might I ask you, can you speak to why we should stop smoking?
So that smoking, is such a that smoking is such a risk factor for all cardiovascular issues, for all vascular issues, not just diabetes, even blood pressure. We see patients that smoke that have peripheral arterial disease. Smoking just increases damage to the cell, oxidative damage to the cells in the body. And so it can exacerbate and make worse your diabetes, your diabetic retinopathy, all your high blood pressure, your hypertensive retinopathy, cataracts, just a lot of complications with smoking. And when it comes to smoking, is it the smoking or the nicotine? So I tell my patients that are vaping, is it the nicotine? So I always say to my patients that it's not just a cigarette that you should discontinue, but also the vaping. When it comes to medical marijuana, I would probably not answer to say that marijuana can exacerbate or make worse. I need to do a little bit more research, but when it comes to vaping, when it comes to smoking e-cigarettes or actual cigarette, those are the ones that I would tell my patients to really discontinue, to stop taking, smoking those or utilizing those, because they just make everything worse, not just your diabetes, but your blood pressure, your cholesterol, and you can be healthy and have changes from smoking. So it's not just lung and cancers that we're worried about, but it's also vascular disease that we're worried about, or exacerbation of the other vascular complications with smoking. So yes, regular smoking, chewing tobacco, e-cigarettes, those patients should discontinue those. When it comes to marijuana, again, I would have to look into the research when it comes to marijuana and diabetes, but I would say that any form of smoking might not be good for you.
And then Dr. Reynolds, does that include, and may I ask you to speak to secondhand smoke for those of us who might live with someone who is a smoker of nicotine?
I'm sorry, say that again.
Can I ask you to speak to secondhand smoke?
I will say that and research has shown secondhand smoke definitely leads to cancer, right? And again, I would say that I would have to look at studies, but yeah, secondhand smoking can exacerbate or make worse your vascular disease, just like it can lead to potential cancerous changes in the lungs. So I would venture to say, yes, you want to limit smoking. That's why I really applaud changes where smokers have to go outside. So you're not breathing in the smoking. So it's the breathing in of the nicotine, right? It's the secondhand smoke, it's the nicotine that is the causative problem.
Okay, thank you. Our next question in the chat asks, does hyperthyroidism or Hashimoto disease lead to diabetes?
Does it lead to diabetes? Yes and no. I mean, any condition can lead to other complications. So I would say when you're working with your endocrinologist and you have thyroid a disease, whether it's hyper or hypo or euthyroid or Hashimoto's disease, it can make other conditions worse, and it can also bring on other conditions, of course. So I would say if you have these condition and you have your endocrinologist, that's someone that you can work with just to check your blood sugar level. It also has to do with, who's in the chair. For example, patients with hypothyroidism tend to put on a lot more weight, more so than patients that have hyper. They tend to be a little bit more thin when you look at the clinical picture of these patients. And we know that weight can, patients get new onset diabetes because of the weight. And that's why a lot of these newer medications, Ozempic and Mounjaro, these weight loss medication, and the American Diabetes Association recommend at least, up to 15 to 20% of weight loss to control patients' diabetes. But there was a big program, the Diabetes Prevention Program, DPP program, that looked at exercise. And just 3 times a week of 30-minute aerobic exercise can help to ward off or prevent you from developing full type 2 diabetes. So exercise is also important. So I know these weight loss medications are out there, or some of these medications have great weight loss effect that are out there for patients that have pre-diabetes. And a lot of patients are being put on that and they have comorbidities such as hypothyroidism and other conditions, but they're being followed very closely by their endocrinologist. So you want to just continue to be monitored very closely by your endocrinologist.
Okay, thank you. We have just a few more minutes in the chat, so I want to respect your time, Dr. Reynolds. I also want to ask, as the holidays approach, and we're going to be with our families, many of us with our families, what do we do with all these delicious desserts and family recipes coming? We want to be mindful of our weight. We don't want, to get diabetes, pre-diabetes. What do we do this time of year when the food is just everywhere, so prevalent?
What I always tell my patients with diabetes, you don't really have to, you do have to watch what you eat. So yes, you do have to watch what you eat. And the sugary foods and the sweet foods, yes. But for example, one of the things I say, like, so in an African American community, Afro-Caribbean community, greens are important. It's how you prepare the greens. I think collard greens have very good nutritional value. It's how it's being prepared. You can prepare it in a more nutritious way. A Mediterranean diet has been shown to be very beneficial in patients that have diabetes, as a diet for patients that have diabetes. Around the holidays, I would just say watch what you're eating. Be careful. I know it's very tempting to eat the sweet potato pie and the pumpkin pie and other dessert. But just watch what you're eating when you have diabetes and make sure that maybe it's prepared in such a way that it's healthier. I'm not a nutritionist per se, but I will say consult your nutritionist on what you should be eating. There are other resources because patients with diabetes should not be eating, fruits, of course, because it has sugar. So I think just reviewing what patients with diabetes should be eating during the holidays. I think it's okay to eat the turkey, just eat in moderation. Make sure that you're watching your blood sugar level because we see a lot of patients that come into the clinic after the holidays and their numbers are high because they partake in their family tradition. You just want to be cognizant that you have this disease and you just can't have that whole sweet potato pie as your other family members, or maybe how it was prepared. If it was prepared a little bit more nutritiously, then maybe you can have that. So, yes, the holidays are coming up for my patients that have diabetes. And I'm not saying not to partake, not to enjoy, but enjoy with a limit. How about that?
Okay, okay,
I do want to go back to the diabetes ketoacidosis. I just want to add, it's a medical emergency. I mean, your sugar level is very, very high. Your body, there's no insulin to break down that sugar. And so patients that experience diabetes ketoacidosis, they typically hospitalize to bring their numbers down. So it is a medical emergency for patients that have diabetes.
Dr. Reynolds, we have one more question, it looks like in the chat. And the question reads, what exercises benefit the eye?
Yes, all exercise benefit the eyes, right? Cardiovascular exercise is important not for overall health, but for eye health as well. Nutritional eating, I would say lutein and zeaxanthin, which are these two carotenoids that are important in patients that have macular degeneration, has been shown to be just as efficacious. And for patients that have diabetes, there are some diabetes vision formula that patients can take that have these nutritional values. I would say talk to your physician about these as well. There's a DVS formula, diabetes vision function formula, that is on the market. And when it comes to exercise, all exercise, I think the DPP program, 30 minutes of aerobic exercise 3 times a week is very efficacious and can help not only with your diabetes, your high blood pressure, your cholesterol, but definitely with your eye health. I would definitely recommend, if you do your steps, I've heard 20,000 steps a week is just as efficacious as 3 times a week doing aerobic exercise. Walking more, getting out more as good exercise. You don't have to go to the gym and be on the treadmill per se. As long as you're walking and you're eating healthy and you're moving. I want my patients with diabetes to move. That can also not only help your diabetes, but also help your eyes as well.
Okay. Thank you, Dr. Reynolds. And we have 2 minutes to go. And so we want to respect your time. But before we all leave this webinar, I'd like to ask you, what would you like, what's a key takeaway for all of us for moving forward as we close 2024 out and look toward a new year? What would you like your audience to do?
So what I would like the audience to do, and that's why this is important for me, and I'm so always happy to participate with the National Caucus for Black Aging webinars on these important topics, is to just know that the eye exam or the eyes, the eyes are the window in. And so I always tell my students and I always tell my patients, an eye exam is more than just giving glasses. We can save your sight, we can save your lives. A lot of time patients don't know they have diabetes, and it's through an eye exam that we detect changes in the blood vessels in the eye that lead to the diagnosis of diabetes. And up to 33% of patients with type 2 diabetes, because 8 million people with diabetes don't know they have the disease. And an eye exam is critically important in detecting that. So an eye doctor is really critically important. The second thing I want my patients to know is 1 in 4 individuals with diabetes have eye damage. And the earlier the detection, the better we are at preventing loss of vision. So that's why it's important to have a comprehensive, dilated eye exam every year. And then last but not least, know your numbers. Your numbers are important. If you get a 3-month blood test, your hemoglobin A1C number, you need to know that number. When you come to me, I'm going to ask you those numbers, and you want to know those numbers. What's new to the table is time in range for patients that have continuous glucose monitor. So if you have a continuous glucose monitor, your doctor may ask you what your time in range is or look at your monitor. But know your numbers, know your blood pressure. You want to make sure your blood pressure is less than 130/80. Also know your cholesterol numbers. I know my numbers. Just know your numbers. Your LDL, or the bad guy, should be less than 100 and definitely less than 70 in some cases in patients that have diabetes. So know your numbers. I know that was a lot, but bring your journal with you when you go to the doctor. Write your numbers down. Know your numbers. The more you know your numbers, the more that we can prevent these complications in the back of the eyes. And sometimes the damage is irreversible. We can't improve the vision. Our goal is that the vision doesn't get worse, of course, but the most important thing is to detect it earlier before there's loss of vision.
Thank you, Dr. Reynolds. That was a perfect segue. Thank you. We are very thankful that you joined us this afternoon and for your kindness and willingness to always support our efforts here at NCBA. On behalf of NCBA, we'd like to wish you a happy Thanksgiving and holiday season, and we look forward to seeing you in 2024 and 2025.
Thank you. Thank you. Thank you, everyone, for having me. It was such a pleasure. You have a beautiful day, a beautiful Thanksgiving, and a beautiful Christmas.
Thank you, Dr.
Thank you,
Reynolds.
Dr. Reynolds.
Thank you. Have a good afternoon, everyone.